Okay, so today we're going to go ahead and talk about a general approach to the eye. Patients presenting with ocular complaints can be some of the most intimidating patients in the emergency department. The eye is this mystical organ, and the stakes are super high when dealing with it. When a patient presents with an ocular complaint, it is important to first make sure that you do not miss something critical. So the first thing that we will need to do, like we do with all chief complaints, is develop a critical differential diagnosis. The list can get pretty long, so it may be easier to remember if you think of the anatomy. So let's go ahead and draw an eyeball out. We got our globe here, followed by our anterior chamber and cornea, your lens, and then we'll go ahead and draw our lids and lashes. Now remember, this is just a starting point, so don't put all your eggs in this one basket. Reassess your differential and don't early anchor. The first place we're going to start is the lids. So is there any evidence of a periorbital or orbital cellulitis? You can also take this time to look for a hordeolum or a chalazion, which can also present with infectious looking lids. The next place that we're going to look is the conjunctiva, and specifically what we're going to look for is if there's any evidence of conjunctivitis. Now this can be in the viral versus bacterial flavor depending on how the patient presents. We will now turn our attention to the cornea, and what we're really going to be looking for is any evidence of a corneal abrasion or ulceration. And the other thing that we're going to look for is a globe rupture. In the anterior chamber, we're going to be looking for iritis, hyphema, or acute angle glaucoma. The final place is the posterior chamber. I'm just going to zoom out so I have a little bit more room to write. And specifically, we're going to be looking for retinal detachment, and vitreous hemorrhage. So again, this isn't a comprehensive list of all of the things that can cause eye pain or visual loss. We are just kind of using this as a primer so that we have a much more focused approach when we see our patients. So now that you have this long list of potentially vision-destroying diagnoses, you now have to go see the patient. The first thing to remember is that the vital sign of the eye is the visual acuity. And I'm going to draw some stars on it because it's super important. Use the pinhole to correct for any refractory error. A bad visual acuity with pinhole is an abnormal vital sign that needs attention. Never call an ophthalmologist without having a visual acuity. If the patient's visual acuity is so bad that they can't even use a Snellen chart, just try to see if they can see color or light. Even that information will be immensely helpful for the ophthalmologist. Another important vital sign is the intraocular pressure. If your patient has a potential globe rupture though, you may not want to measure this because it can essentially squeeze out gross vitreous humor and you could also injure the eye more. Now let's systematically look through the eye. Start with the eyelid, looking for periorbital or orbital cellulitis. Does the eyelid have signs consistent with cellulitis? Is there erythema, warmth? If there's pain on extraocular movement, then that could be more consistent with an orbital cellulitis, which is more serious. Then look to see if there's evidence of involvement of the gland of Zeiss consistent with a hordeolum or the meibomian tear gland consistent with a chalazion. Next, we'll look at the conjunctiva. Did the patient report on history that his or her eyelids were glued shut with eye crusties? If yes, then there is a possibility that the patient has a conjunctivitis. When looking at an injected sclera, pay attention if there is perilimbic sparing. So let's go ahead and draw this out to make it easier. Here's our eye. Now, perilimbic sparing means that there's a white area around the iris that doesn't have any redness involvement. So here's a picture of it. If there is evidence of perilimbic sparing, then that's much more consistent with conjunctivitis. If there is not perilimbic sparing, then keep badness in your differential. For the cornea and the anterior chamber, it is now time to look at the eye with the slit lamp. Use the slit lamp to look over the entire surface of the eye, looking specifically for foreign bodies. Be sure to evert the lids and inspect them for foreign bodies. Then put fluorescein in the eye, and with a Woods lamp or cobalt blue light, look for uptake that would be consistent with a corneal abrasion. You can also look for Seidel's sign, which is essentially a greenish-yellow waterfall of vitreous humor that is present in globe rupture. Another key thing to look for is how the pupil looks. If it is peaked or abnormal, then that could represent a globe rupture as well. Now let's shift our attention to the anterior chamber. We're going to be specifically looking for floating white blood cells consistent with iritis. These patients may also complain of photophobia, so that's another good thing to look out for. The next thing that we can look for, specifically in the inferior aspect of the iris, is any layering of RBCs consistent with a hyphema. And of course, we should have already had this, but in case you haven't, get an intraocular pressure if appropriate to look for acute angle glaucoma. For the posterior chamber, try to do a fundoscopic exam. Now, I'm going to be honest, I'm not the best at these exams. So if I have a patient who complains of floaters consistent with a retinal detachment, I immediately grab my ultrasound machine, specifically looking for opacities in the posterior chamber. Now, it's important to remember that an opacity in the posterior chamber could either be a retinal detachment or a vitreous hemorrhage. And that's it. If you found something bad and need to call an ophthalmologist, here are a couple of tips. Make sure your first line is tight and that you tell the ophthalmologist exactly what you think is going on. For example, "Hi, I have a patient with suspected retinal detachment that I would like to consult you on." When you get to the history portion of your sign out, be sure to mention what the ophthalmologic past medical history of your patient is. Don't start with a long laundry list of medical history that your patient may have. For example, instead of starting off with, "This is a 52-year-old male with a past medical history of hypertension, diabetes, hyperlipidemia, CHF, COPD, and cirrhosis," and continuing on, you may just want to start with, "This is a 52-year-old male with a past medical history of macular degeneration." It's important to remember that you're trying to speak the language of your consultant. Finally, when you get to the physical exam, be sure that the first line of this section of your presentation is the visual acuity. As we stated earlier, the visual acuity is the vital sign of the eye. So make sure you have that information and, if possible, the intraocular pressure. So hopefully this helps and will make the eye a much less formidable opponent in the emergency department. Thanks for watching.